we have Jean Catron, our patient and nurse educator, and Amy Willis, our occupational therapist. Thank you.
Thanks. I'll go ahead and do a what is it called, a disclaimer.
Okay.
That we had planned on actually kind of getting together and discussing our presentation, but I have been off for the last few days. So I'm just returning as of yesterday. So we're gonna wing it. So it's gonna be very informal. I do have just a brief, I'm Jean, by the way. I'm the Jean of the two, and this is the Amy of the two. And when Dr. Roach approached me, part of it is also because of my personal experience with dementia, because unfortunately both of my parents have dementia. And actually, the reason why I was gone is my dad passed away last Thursday. So his journey with dementia is done, so, which is a relief. So I'll miss him, but when I discuss some of his behaviors, you'll see where I hadn't had my dad in a long time. And I can really relate to a lot, with a lot of the things, and not only on the caregiver side as far as healthcare providers, but also as a family member, and how you feel when they are acting out when they're receiving healthcare, because it can be pretty stress-inducing when they are acting out terribly and not cooperating while someone's trying to provide care to them. So I just did a really quick kind of review, and there's basically 6 domains of cognition that get affected with dementia, and it kind of depends at what stage they are in the dementia when you start to see this. I think that one of the first things that I have seen in my own personal experience is the learning and memory. A lot of times is the first thing that you begin to notice, where they, especially short-term memory, begins to be a problem, forgetting to take their medications, forgetting appointments, follow-up appointments and things. Of course, there is some perceptual motor function. I tend to see that happen later in the course of the dementia. Language, it doesn't happen with all people who suffer from dementia, but there are times that they do begin to have difficulties, selecting the correct word to express what they're trying to express, which can be a problem if you're trying to get a history on them. Complex attention, especially when you get into, if it is directives that contain more than one task in it. And that's one of the suggestions that we'll have, is that when we give them directions, it's kind of got to be one thing at a time. Take off your shirt. If we're giving them instructions before a procedure, it kind of needs to be one step at a time, because they can't process anything that has several directives in one command. If it's take this pen, sign this paper, place the paper on the table, then go ahead and change into this patient gown, they'll have probably lost you at the take this paper. Of course, also you have problems with social cognition, and this a lot of times impacts, when we interact with the patients, because they aren't always socially acceptable. I always called it with my parents, they've lost some of their social filters. My mom is very obsessed with, she was overweight, she lost a lot of weight, and now she very bluntly points out anybody that's overweight and says, boy, look at how fat he's gotten, and it's very loud when she says it, and doesn't really think about it. Just a little bit about each of these. The complex attention, like I said, multitasking is really difficult for them. And the other thing is limited distractions, and we don't really have anybody here from the med surg floor itself. But one of the things that they mentioned in there is to be careful. Like, this is not the patient that you think, I'll turn the TV on so they're not bored. That actually is more of a problem. Unless they really want the TV on, it's better not to have any kind of extra noises and things, because that just stimulates them more. Executive functioning, obviously, simplification is the biggest thing. Everything has to be simple. memory, they just don't remember as well as they used to, especially that short-term memory, the recent memories. They can discuss things in the past, at length. My mom was a nurse back with Dr. Wishart, and she can talk about being a nurse at Methodist Hospital and having people in the iron lung and how they took care of them, but yet I can answer a question about something happening today, and I'll get asked the same question 6, 8, 10 times in the course of an hour conversation, which can be maddening at times. Language, one of the examples they have is that they can't call it an elevator anymore, it's the up and down and up and down, so we have to sometimes ask questions in different ways, because they just can't come up with that, expressive word that describes the term. Receptive can also be impacted, and they might have some problems with grammar and syntax, pronouns, things like that. Perceptual motor, to give you an example of that, they cannot always connect anymore, like a simple household object no longer is recognizable to them. They can look at a hairbrush and no longer be able to determine if it's a hairbrush. Of course, like I said, social cognition, and I think that's the one that causes the most problems to us as family members, is they just aren't themselves anymore, and at times they don't think much about hurting other people's feelings. I know that was one of the things that came up, I think, even as some things that have happened here at the hospital with patients, is that sometimes the patients are brutally honest in what they think, and that it can, as a caregiver, kind of not always feel really good if they tell you they don't like you, or that you're ugly, or that, that they're going to say exactly what comes to mind, and oftentimes won't even remember it afterwards. The problem, of course, with these patients is that they're higher risk for adverse, falls, dehydration. They can't sometimes express their pain to us. One of the things is to think about looking, we watch their facial expressions, because a lot of times if they rub their heads a lot, or they grimace, that might be they can't actually tell us they're in pain, but we look at the facial expressions. Consistent routine, and I heard you mention about don't argue, and I mean, that is actually one of the first things, and that was the hardest thing for me with my parents, because I constantly tried to reorient them, constantly, to say, no, my dad kept asking me about if I was still building houses, and I think, and I finally just went along with it, and actually we had better conversations, and a lot of times I just redirect. It's the other thing that they suggest, if they're really stuck on, like, they don't like their IV in their arm and things, is, cover it up so they can't get to it, but also then just ask them something random that has nothing to do with it, and try and get them in a different place. And then the last one is just some different tips that they say for communicating, that get on their level and make eye contact, because they get scared pretty easily. Tell them what you're gonna do before you do it. Speak calmly, slowly. Don't say remember. I say that tends to get them more upset, and I know it did from my parents. It didn't matter if I said, don't you remember I answered that question 10 minutes ago? They didn't remember. And then the biggest one is do not argue. It gets you nowhere. And that's why they suggest, like they say, ask them for one of their favorite stories, or just try, especially if they're very agitated about something that's going on as far as a procedure or a treatment. It's kind of like dealing with toddlers. You distract them onto something else, so that they'll cooperate with you while you're trying to provide care.
Thank you very
Amy.
much. My turn. So, I'm Amy Willis. I'm the occupational therapist here at the hospital. I've been practicing for about 13 years now. And why would you ask an occupational therapist to see your patient with a neurocognitive disorder, maybe a dementia? What is my role? Why would I check ADLs and physical disabilities, right? But we also do look at that cognitive component because especially here in the hospital, primarily on the inpatient side, we're looking at how do we decide what is the most appropriate environment for that patient to return to, and how do we support the caregivers, if necessary. So providing help with discharge planning as well as family caregiver education, and then also within the hospital helping to determine, being part of that team to determine, okay, is this a delirium? Is this a reversible dementia versus an irreversible dementia? We could talk about, okay, is it a UTI, pneumonia, something that's gone undiagnosed? Is it poor medication management? Is it poor nutrition? Is it something metabolic, hormonal? Is there an underlying infection? We're all part of that team to figure that out. Versus is it a reversible neurocognitive disorder? Do they have Parkinsonian dementia? Do they have Alzheimer's? Vascular dementia? Is it a delirium? Is it post-anesthesia? Chronic brain injury? Any of those things? Drug or alcohol abuse? Medication mismanagement? So I love this quote. Stole it from our dementia training manual that we have in our therapy department. Our job is to create a world in which the person can function with their level of dementia as opposed to trying to change the person to fit our normalized world. It's just not going to happen. This is where they function now, so how can we be part of the solution? Living versus existing, because a lot of these folks, they are just existing in someone else's world. I had a caregiver say to me a few months ago, I'm living two lives now, because she's living her life and she's living her husband's life, because he doesn't know what he's doing from one minute to the next, and so she has to live that out for him as well. And she says it's exhausting, and I can't even imagine how exhausting that might be. So for the caregivers, for the hospital staff, to even minimize hospital staff load, for a patient with behavior issues. One of our roles is to help to figure out what behaviors are going on, what environment can we set up for them that is going to be the most effective and require less supportive care from extra staff, or do they need more supportive care? I like what Jean was talking about. There's that theory of regression with a dementia or a neurocognitive disorder for whatever reason. It's really like, how does a baby get its needs met? It cries, it acts out, it shows some behavior, and it's your job as the parent to figure out what's behind that behavior. Are they hungry? Are they wet? Are they tired? It could be that simple, and that person just can't verbalize their need. So specifically, my role as an OT is to identify the client's highest level of function in all activities, develop a care plan to be implemented by the care team or the family and caregivers, help in that process of determining an appropriate discharge environment. And then it's all of our jobs in managing, in assisting in that dementia area, specifically for those high risk quality areas such as fall prevention, weight loss, behavior management, loss of ADL function, and skin breakdown. Another very important role we play is explaining the behavior to the caregivers. And I do have quite a few resources. We do, as a therapy department, have several resources that we can provide written information to caregivers. We can do some cognitive testing and determine what level, if you're familiar with the cognitive levels, the Allen cognitive level, determine what level of identification is at, and then help to describe, what's going on with their loved one. And unfortunately, sometimes the person to tell them, no, it's not going to get better, but this is the best way to interact with your loved one and explain some of those behaviors, because as we all know, the person with dementia is going to be most hard on persons with whom they are the closest. So explaining that behavior sometimes just takes a lot of load off that family member, and to reduce their stress. Some important things to remember is that person always remains inside the patient, and it's our job to learn who that person is, and then design a plan to incorporate their individuality, their social needs, and then also focusing on their abilities, what the person can still do, and really try to promote that, thinking about ability versus disability. I think that's our role in all areas of healthcare. The other thing to think about is that no matter what stage of dementia this patient is in, there's always going to be an internal need to be successful. So how can we help that person to be successful at the level that they really can function? And then at the same time, not accepting behaviors as normal, helping them to find a way to be socially acceptable when possible. Sometimes living in the world of unreality is okay in most settings, but maybe doing that, maybe talking about the thing that doesn't exist anymore, just in order to keep those adverse behaviors, those outbursts at a minimum. So, as OTs, this is Jenny, our OT assistant, we might do some cognitive testing. We're going to look at all the areas: memory, attention, safety awareness, judgment, problem solving, sequencing ability, and then a higher executive functioning if necessary, in order to determine, okay, can this person stay by themselves? Does this person need medication management? If we give them a pill box, are they going to remember to take the pills out of the pill box? Are they going to remember that they already took their morning pills, or even what day of the week it is? Whatever that level is, as well as a therapy team, we're going to be looking at the physical level of function as well. So you have the function includes cognitive component, physical component, sensory component, and emotional component. So if a person has a limitation in any of those areas, it's going to affect their degree of independence. Cognition is the primary determinant of a person's maximal level of function in every activity. You cannot perform higher than your cognitive ability level. So they may be physically just fine, but if they don't have the cognitive ability to, say, get out of the chair, how are they going to then walk across the room to use the restroom and not be incontinent? Or get up and go to the refrigerator and get something to eat if they can't recognize the hunger urge. The other side of that is allowing excess disability as a caregiver, as caregivers, not putting that disability on that person and not expecting them to be able to do for themselves. We see those people that come in and they are the shape of a wheelchair because they cognitively can't function, so it's safer for them to just sit, and then they become the shape of their wheelchair because they don't, that's an extreme, but that is the reality. So. Limit distractions. Things are hard to think. So, I don't know if everyone was able to get a copy of. I just gave a few ideas of do's and don'ts. Just some quick ideas. These are a lot of things that we would share with caregivers. The nitty-gritty on dementia. Kind of piggybacking on what Jean has already said. Giving one-step command. It's all about simplifying. Increase processing time. Can they hear you? Do they understand what you said? Does it take them just a little longer to respond? Low stimulation environment. We talk about, we turn the TV on, they like some noise. Noise is common. Well, noise and lights is a different situation. Maybe keeping the lights lower, even decreasing the number of staff members that are going to be coming into the patient's room. And we talked about lowering our tone of voice. Something that we were discussing is, what about familiar music? And often, what was it with your dad?
Big band.
Big band. That was calming to him because that's where he was. He was, long-term memory is great. Short-term memory is typically non-existent. So that's going to be, soothing to him. Reminiscing is fun. Not saying, remember I told you already you brushed your teeth, but hey, remember when we went fishing? And those are the things they're going to want to talk about often, and that's going to be more soothing. And you probably are going to go a lot further with whatever medication you need to give or whatever testing you need to run. I don't advocate lying ever, but just going with it. That truck is down there. There's a guy in a truck waiting downstairs for me. Can you tell him I'm going to be a few more minutes? So step out the door and come back in. Did you tell them? It's okay. They're waiting for you. They'll take care of it later. Just go with it. It's not technically lying, right? But if it's what calms them down enough to get on to the next thing, because they're not going to remember 5 minutes later, or it might be a hallucination they're having, and they might keep going with it. So meet them at their level and argue with them, and then not taking their patient behavior personally. Not arguing with patients. Interesting. Recently, I had a family member pass away whose spouse had very severe Alzheimer's, and the Alzheimer's Association, the family called and said, what do we do about the funeral? Because, as far as she knew, she was just waiting for him to use the grocery. And what they said is, just tell her once, let her see the body or not. They don't even necessarily recommend that you do that. And then take her away. Don't have her stay for the funeral. And don't tell her again. Just tell her, he'll be back later. Because then they're reliving that every time. Every time the death of their spouse. So, in any case, you're in the hospital, and this is what we need to do. You have a pneumonia, and we're going to treat you. And just let it go. Reorient them once, and they'll just keep hanging on with it. So, Dr. Roche and I often joke that we think it would be important to have a baseline cognitive assessment on ourselves now. One of the things that we do with the SLUMS test that I've passed out, that's our preferred cognitive test. That gets a little more in depth than any mental self-exam. Don't peek at the end. Don't peek at the questions yet, because I'm going to let y'all test each other today. Dr. Roche and I often discuss that we think we need a baseline so we can find out how we are later. It is one of the things that we can do here, and you should be able to look up in Sovera, whichever. I don't have access. So Dr. Roche looks it up for me. We can look at someone that we had 6 months or a year ago and say, oh yeah, let's test them again. Or even sometimes post-op we'll test someone if they're really, okay, we don't know if this is normal or if this is off. And then test them a week later and see, okay, well, maybe that was anesthesia related. This was, UTIs cause all kinds of crazy things. So then we have a baseline, and we can't even serially test them throughout. Typically, Jenny's going to be the one doing the testing each time, just because then you have that inter-rater reliability also. So a couple of things on the test. Yeah, go ahead and pass around a pen there. I'll let you
Pen do I want?
pair
Let me see,
up.
that's a big decision.
I didn't refuse distractions.
Simplify.
So you push verbal.
You always like this, Kelly.
I have something, I don't know.
You can't.
Message on the testing on number 8. Don't get a point if you get 87 right. Back to the stage, so before you move on to question where, you know, the 649,
Yeah, maybe don't tell us yet.
never mind, I can't tell you yet. Just ask the question as it is,
No
as
hits.
is written. No hit.
So we're asking questions, we're not debating.
No, you get to ask, partner up and ask your guy next to you. You're right there.
Do you really, are we filling this out?
No, you're gonna test the person.
You wanna go first, or
What
we
is
ask
that?
first? You don't just look.
You're superiority dementia. Yes, no.
All right.
What day of the week is it?
What year?
It's Thursday. You know why I know it's Thursday? It's like Easter.
Please remember these 5 items. I will ask you what they are.
We have $100 powder started by a dozen hours restored by a dozen apples for $3. How much did you spend? I know. And a tricycle for $20. How much did you spend? $100. And you go to the store and buy a dozen apples for $3.
You have $100 and you go to the store, buy a dozen
And a
apples.
tricycle for
The
$20.
apples, the total number of apples is $3.
How much did you spend?
How much did you spend?
So I
And you buy a dozen apples for $3.
Tricycle for $3. How much did you spend?
Oh.
And how much do you have left?
I can't figure it out. How much do you have left?
Please name as many animals as you can in 1 minute.
77.
Apple with $3. As many animals as you can in 1 minute.
Coyote, wolf, tiger, lion,
Questions, did you hear that?
Go, Ryan.
elephant,
Naming how many animals in minutes.
mole,
So, you get 3 out of 3. 15.
What were the 5 items I asked for?
pen, tie, house.
I'm going to give you a series of numbers. I can give them to you back.
Yeah.
87. 600.
7,000.
So the,
8,536.
but
I'm going to give you a series of numbers. You just spend hours markers to me back 10 minutes to
What were the 5
For example, if I
questions
say 42, you just spend it on 11
So it's 7,000.
Me too.
I'm going to give you a series of numbers, and I would like you to give them to me back.
649.
For example, if I say 42, you would say 24.
8,537.
640.
Place an X in the triangle.
Can't throw.
649.
Okay, I think I have to show you this.
so doing this,
That's what I say, 'cause I said
10
600.
minutes to 11.
Except 649. 8,537.
Which of these three?
Okay. Put an X in the
Like,
triangle.
you said you can't do world records. That's just like that.
No, it would have,
So on the,
this,
on that,
you're saying that these dimensions are all the same.
Tell you a story,
This square is half the triangle, so it
I'd
has
like to
to
ask you some questions. Jill is a very successful
No, I look against the red, it says
the clock face.
55 or 58. It's not 11 yet.
It's 10 to 11.
She made a lot of
She and Jack lived happily.
Plus, place an X in the triangle.
She didn't stop working, she stayed at home.
Which?
What did she do?
I'm gonna tell you a story.
What state did she
Listen
live
carefully, because afterwards I'm gonna get asked you some questions about it.
Jill, what state?
Was very successful.
I'm guessing that
She
she
made
knows
lots of money in the stock market. Then she met Jack. A devastatingly handsome man. She married him, had 3 children. Lived in Chicago. Then she stopped work and stayed at home and raised their children. When they were teenagers, she and Jack lived happily ever after.
Well, how can I do this to you? You already have forget it.
Yeah.
You just know, you would know it. You would know it.
What work did she do?
All right. I've been told that that's very good.
Where did she go
You
to
know why?
work?
You know why this is? You know what this is hard? Because your brain,
Were they?
units of 3. That's what you.
Any others?
I'm 649, 946. But then the last one, I forget. The first one, I forget this one.
What state did she
Please,
live
before this
in?
is all, please place an X in the triangle.
Yeah, 8537 and 7358, which is 7,358. Yeah.
That was tricky. Because when she go back to work, it said when they were teenagers, she went back to work.
So you're gonna give this to everybody?
The million.
Well, age, you know, age.
Can I make some comments while,
Please
hey,
look.
everybody?
Listen carefully.
You who? Everyone. Can I make some comments, because this, this is very, it's very interesting that it is very propitious that this subject word, we know that word, everyone? Look it up, you know. Go to college. No, anyway, that we would bring this subject up right now because, you know, an area in the anesthesia that's getting bigger and bigger is people with post-operative delirium. And we're really struggling to find out why patients become so disoriented and have the problems they do. A couple interesting things. One is that there's 2 times a delirium that happen to our senior patients. About 90% of the time it's a non-agitated kind of benign lethargic delirium that sometimes it's not, everyone thinks that they wake up, they're thrashing about, they don't know where they were, or you can't settle them down. But that, most of the time, that's not what happens. But the pragmatic things that you talk about are the exact same things that happen here. They are lost in terms of where they are, maybe who they are, their environment, and what has even happened to them. They may not realize. And the conundrum is, what have we done to a patient to engender this kind of behavior? What has gone on? And the interesting thing is, everyone's trying to say, well, everyone said, well, it's that general anesthesia, it's that gas you give them, it's bad, it's terrible. Well, British, and you can write this down, British Journal of Anesthesia from this month to the last month. Look it up, post-operative cognitive dysfunction, there's a big article on it. And probably ought to put that in your stat too, because there have been numerous studies that have looked at general anesthetic, regional anesthesia, and even sedation. And you know, the odd thing is, there's really no real difference in the occurrence of this clinical syndrome. Even if patients get a regional anesthetic with a little sedation, it's the same as general anesthesia. And that was very surprising, because everybody thought it was inhaled agents. In case you don't know, the main medicine we use are vapors. They're methylethyl ethers, and they go in and out through the lungs, and they probably change membranes in the brain and the spinal cord. So transmission is altered. And, you know, obviously, if you have somebody who has Alzheimer's, their membranes are already altered. And then you throw a little gas in there, they don't, it's like older patients that that when they break a bone or something, they don't heal. It takes them 3 months instead of 2 weeks, like a kid. Well, probably the same thing is going on in their brain, to a small degree at least. That whatever medicine goes in, it takes a while for the membranes to come back to normal. That's always been the thought, but the disturbing thing is, even if you control for that and you would take the anesthetic out and you would use things like propofol, the incidence of delirium is probably exactly the same. So it's a little unsure. So when you see a patient that's come back from the operating room who has this problem, it's probably multifactorial. Now again, infection, dehydration, sepsis, hypothermia. These are all things that can add to it. And you say, well, you give them pain medicine. Well, pain medicine can cause dementia, but it also, pain in itself can cause dementia. So if you don't treat it enough, you can get people that become delirious or have problems. So it's a very interesting conundrum that there's really no good answer. There's no thing that I can say, well, I know this person has the potential to have, we know they have Alzheimer's. How am I going to mitigate against maybe a decline in their function after surgery? Because unfortunately, if people get delirious in the hospital, they've done longitudinal studies that show their mortality is increased significantly. Those people die within a year at a much higher rate. It's almost like a hip fracture is a marker of death for someone. If they fall, break their hip, a year later, 80% of those people are dead. Go look. I mean, 70% of those people are dead. And so it's almost to that level. So it's something that, I'm very aware of. I try to minimize whatever I can. Now, maybe that may not be the right thing to do. I don't know. But you try to keep their blood pressure up. You don't let them remain hypotensive all the time, thinking that maybe cerebral blood flow may be an issue. So it's really kind of a very, very interesting thing. And I wish I could tell you the next time you get a patient like this for my anesthetic that I could have done something different. But at this point, I've got nothing I can hang my hat on.
It's interesting that you mentioned it, because long before Dad was diagnosed, he had 4 aneurysm repairs in the course of 5 years.
What kind of aneurysm?
Let's see, popliteal twice, and this one popliteal, AAA, and iliacs.
Okay, so he had a AAA. It was a general. It wasn't done endoscopically. No, okay, that's
with each
a
time,
rough surgery.
Yeah, and with
That's a
each
rough
one of
surgery.
those surgeries, even the popliteal, he would have some dementia afterwards, and we'd never done that before. And it wasn't long after that they began to notice that, and that was the first signs that we noticed with him. And it was, and like you said, it wasn't thrashing or anything. He'd pick at the air.
Exactly.
He was blowing something like this. It was he wasn't hurting anything. He was picking apples, and there were nuns in a rowboat on the roof.
The interesting thing you say that, which the corollary to what she just said is that what we're doing is, by giving those people a general anesthetic, is you're showing what the future's going to be. Something's wrong with their neurological connections. We're stressing it, whatever you want to call stress, with our anesthetic, and they'll decline. Usually they recover. The unfortunate thing is there are studies out there that show that 6 months after a general anesthetic, a significant number of people have a neurocognitive decline that never returns to baseline. And so it's a shame. The classic example of this is, Uncle John, he had that heart operation and went on bypass, and he's never been the same. But we know that bypass incites an incredible inflammatory reaction. You get small vessel disease in the brain. They have decreased perfusion, and they have brain cells that die. And that's you're exactly sure that we're almost exactly sure that that's what happened. So we know that, but anesthetics in general, it's a real conundrum.
And it got to the point where I know, and I think that's what we see in patients in the hospital, that any type of interruption to their normal routine, even if they haven't had surgery, you know, getting woken up a little bit, being in a different room and not
Yeah.
at home is all it takes to just tip them right over the edge,
Exactly.
and we lost them now. And Dad did actually fracture his hip, so it's fractured his hip in October, so, and that was kind of, then things went very quickly.
Yep.
But of course, there's no way to remind me not to get up without a walker, so.
So then you put an alarm in his chair, that's
Yeah.
adaptation. that
Yeah, but
you're-
you know, by the time the alarm goes off, he's already on the floor, so.
So know that your folks that you have under anesthesia, if they're going to go through delirium, they're going to come up to second floor where we are going to put those adaptations in place and help them.
Does Haldol help? You two, you tell me, does Haldol make a difference?
Absolutely. At night, especially.
What does it do? Do you know, I mean, what's the putative mechanism? I'm not trying to slam you.
Pharmacology, I don't know, and even in hospice too, when patients start having psychosis,
When they're
it's better
dying,
than using
right.
Ativan or benzo, it works better.
Will, what do you think? You use it in the ER much?
Well, I like Haldol, but it's generally not considered very good for older adults, and it's considered to make their delirium worse. So I'm always, I use it sometimes, but I'm always kind of careful about it. But the problem is there are no good choices in older adults. Everything's pretty much considered a bad choice.
Right, well,
Benzos
that's,
are considered a bad choice, Haldol is considered a bad choice, so there's not a whole lot of options.
I just want, because I saw mention in my reading that that's probably the one drug that seems to tame the savage beast if it needs to be done, so.
We use benzos a lot.
That's-
I think
We
it's
use all those
good for like short term, like one or two times and
Yeah,
then
right.
switching to something else.
Okay, very good.
Yeah.
There's a,
So in the pinch, it's good at night.
there is a list of medicines that you're not supposed to use in adults. I forget what the name of the list is. I'm guessing somebody here knows what it is, and I think Haldol might even be on that list. I know Flexeril is, and I know there's
So it's like.
Well, Ativan is dope. Ativan, it's a unique drug because the effect of Ativan has nothing to do with its serum level. It gloms onto a GABA receptor in the brain, and in more mature people, it lasts for days. It won't go away. I mean, it just hangs around for a long time. So you don't want to use Ativan in your older population. So.
Well, thank you guys very much, and thank you all for coming. Hopefully you learned some things on dementia. You can get along with your dementia patients a little bit easier down in the OR as well.
You know, I was gonna say, my wife, she always gives me one-step command. She says I screw everything else up. And she says it 4 times to me, give time to process. She keeps beating me with it as I'm going to do it. You know, this is called nitty-gritty on 30 years marriage for husband. Life. Yeah, there it is. That's what I'm gonna do.
That's how it works.
There you go.
Do what we say.
Don't do what you think. No. Don't do what you want to do. There you go. Yeah.
I was gonna stop in and say hi to him.
Oh, good. We get to hang out, Will. Let's go to the bar. We got time? Fit a couple pops in.
Did anybody not pass their slums?
Oh, I should.
You're a great tester.
Thank you.